of my discussion. And the first question that I got asked by our research assistant was, are we going to go for tomography or topography? And as we all know, the basic difference is in how much each technology can visualize the posterior curvature. The topography, most commonly, it is based on Placido disc, but could also be on interferometry. Usually only measures the anterior curvature of the cornea, which means it's limited in its depth inside the eye, and it's limited in the posterior corneal evaluation, which we can get a look at using tomography techniques. So in addition to Placido, you have other techniques to visualize the cornea. One of them is videography with Scheimpflug technique or with swept source OCT. A lot of different machines use a combination of either or any of these three mapping techniques. The one that we're using here, and we're going to discuss mostly, is the Scheimpflug technique with the pentacam. So why do we talk about tomography before cataract? As you all know, it's a good, useful way to screen for corneal ectasia, to screen for post-refractive corneas, for any irregularity in the astigmatism. It is a good way to select your IOLs in terms of spherical aberration, toric IOLs, presbyopic correcting IOLs, and most importantly, in irregular corneas, especially in scars in patients who had keratoplasties or keratoconus, you want to know where you're standing at with those corneas and what you can offer the patients as IOL options. Also, you always have this unhappy patient who is 20/20, but he either has a change in, he or she either has a change in myopia, an advancing myopia, still getting to 20/20, or he has a change in astigmatism, ever so frequently changing glasses. And so, and on exam, his lens looks totally clear to grossly, but when you look at the Scheimpflug, you can get data for lens densitometry, and that can give you an idea of an early cataract that's forming, and that can explain his changing symptoms. So we're gonna look at a step-by-step approach into evaluating tomography. We're gonna check lens densitometry, the regularity of the topography, higher order aberrations, spherical aberrations, and last but not least, astigmatism and corneal power calculations. And we're going to use two main reports that are available to us in all Pentacam's machines, which are the pre-op cataract report and the holiday EKR report. And we're going to talk a little bit about each one of them. So let's start first, dive in with the Pentacam pre-op report. This is a nice report because it actually shows you two ways of looking at the corneal curvature. So the first way is the SIMK, which allows you to see the anterior curvature of the cornea, and the second way is the map of the total corneal refractive power, which is a Pentacam-derived index that derives the corneal power based on the anterior and the posterior curvature of the cornea. And this is a nice way to see the whole cornea, including the posterior aspect of it, rather than just the anterior part of it. Also, you can also look through the same report at the pachymetry of the eye, and that should give you a certain idea when you're offering patients multifocal IOLs or when you're offering patient toric IOLs. There's always a chance that you might want to do an LVC later on them, and you want to know that this is always a potential. A very nice thing about this pre-op report are the data that are valid over here. So you can check the higher order aberrations in the cornea, and usually a mean higher order aberration is about 0.37 micrometers. It becomes suspicious, and you don't want to go for any premium IOLs whenever it's above 0.660 micrometers. Another nice thing about this view is that it gives you a back-to-front radii ratio. We're going to talk a little bit about that, but that basically tells you if the patient has had post-refractive changes, post-refractive surgeries before. Also, if you take another look here, you can see the spherical aberrations. I'm sorry, can you see my cursor? Yeah. You can see the spherical aberrations in each and every cornea, and these aberrations are usually within the normal if they're 0.27 to 0.3 micrometers. This is the corneal spherical aberration. These are important because they allow us to determine at different steps what kind of IOL to put in. So we're going to dive into each one of them alone. The spherical aberrations first are, as we all know, because the cornea is a prolate cornea and it is steeper in the center than in the periphery, the images are more displaced centrally than periphery, and you end up with something that looks like this picture, where the images are not totally focused on the same retinal spot. And usually the anterior cornea has a spherical aberration that is stable throughout life of 0.27 to 0.3 micrometer. Whereas your lenticular lens usually has about minus 0.2 micrometer when you're younger, but it becomes more and more positive as the lens ages, which means that more and more spherical aberrations inside the eye, and it stops correcting the general positive spherical aberration of the anterior cornea. So we usually want the eye to have a minus 0.1 micrometer of spherical aberration for an optimal contrast sensitivity and an optimal vision quality. So in most patients, you'll find that the cornea sits in the 0.27 and 0.3. So you're okay to do your regular aspheric lenses, and like Technis, Acrosoft, or the Physio lenses, they're all aspheric to different degrees, and you're okay to do any of those. But in your post-refractive cornea, like in this patient over here, who obviously has a post-hyperopic treatment, his spherical aberration goes to about minus 0.7. So it goes all the way to negative, and it's pretty negative. In these patients, you really don't want to put an aspheric lens, which can increase that number and create even more less contrast sensitivity. So in these oblate corneas, you want to use a spherical lens, so you might want to go with the Sensor lenses or the MA60AT. The changes that occur from the spherical aberration in terms of visual quality are mostly an add-on to whatever you achieve with the sphere and the astigmatism. So if you have a post-PKP patient who will not get into a perfect astigmatism correction and sphere correction after the surgery, this plays a minor role in that. But in your premium IOL patients who you want to reach and achieve the best target possible, you also want them to have the best contrast sensitivity possible. Also, another point that I mentioned earlier is that back to front radii ratio. That ratio that you have over here is basically the radius of curvature compared from the back surface to the front surface of the cornea. And that ratio, as you all know, will change with the refractive surgery. So like in this patient who has had my hyperopic treatment, you can tell here by the steep central cornea. You can also tell by that back to front ratio, which is above 82%. A normal back to front ratio is anything around 82%. If it was a myopic treatment, then it's actually less than 82% usually, and that is a direct, fast indicator of whether the patient has had the surgery or not, if you have missed that from the history. Another nice item that you might take out from the pre-op cataract report is this Scheimpflug lens densitometry, which is a fast way of looking at the internal structures of the lens and taking a look at either an early kind of changes of cataract or a very significant change. And if you notice these reflexes over here, this is the Bowman reflex, and you always compare the internal reflexes of the lens to that reflex. When they peak out like that, it means this is an early cataract, and this patient might be possibly starting to have some symptoms of cataract that are otherwise not noticeable on exam. So we basically discussed lens densitometry so far, topography and how to look at the back to front ratio. We've discussed higher order aberration, spherical aberrations. Now we want to discuss a little bit more the astigmatism. The pre-op cataract report gives you an idea about the total corneal power, the SIMK, but the Holiday EKR report gives you a much better idea about the astigmatism, and that's because it employs something called the equivalent K reading, which is also a pentacam specific index that was calculated based on the anterior and the posterior curvature, but adjusted in a way that it can fit into any IOL calculation formula that you can use, which is the main problem with the total corneal power, that you cannot actually always implement in different corneas without adjustments. And this EKR is something that was created by Dr. Holiday. And what you can see here is basically the mean EKRs in the 4.5 millimeter zone, which is the central zone in the cornea. you can take a look at the axial and the tangential maps, and you can take a look at how regular the astigmatism is, but also you can take a look directly at the elevation on the back to front. Any hotspot over here can pinpoint an astigmatism or a post-LASIK ectasia, in which case you want to probably hold off on any toric IOL if this is highly irregular. Also, in the same view, you can take a look at the pachymetry minimum, which is the minimal, the point of least thickness in the cornea. And that point is usually pretty central in most patients, pretty central, probably a bit temporal in most patients. If it is inferior, it would indicate keratoconus or ectatic changes. And so this number over here, the pachymetry minimum, the Y, if it is above 0.67 millimeter, you're kind of iffy about this cornea and it might be an ectatic cornea. Another interesting value that Holiday added to this report is this estimated pre-refractive K with the refractive change. These data are back calculated based on this back to front ratio and on the EKR readings, and it gives you what it is estimated if the patient has had refractive surgery, the pre-refractive surgery K, which can help you better calculate your estimated lens position after the surgery, and that's better calculation. Also, although we don't use it for that, what is interesting with this one is that it can give you a direct way to see if this patient has had refractive surgery or not. When the change is 0, it means that this patient hasn't had anything done before, and that should be okay. In another view, you can take a look at the chord mu here, and we're going to discuss it more in details when we reach the aberrometry. But this chord mu is basically the angle kappa, which is basically the difference between the visual axis and the central of the pupil. And usually you want that number to be less than 0.4 if you want to do multifocal IOLs. So basically from this picture, you've had some angle kappa, you've had some higher order aberrations, you've had your evaluations of the if the patient has had any post-refractive, and you've had evaluation of any ectasia, along with how the astigmatism look and the central astigmatism with posterior and anterior curvature involved. So it really gives you a more holistic view about the cornea that we're about to calculate for cataract surgery. The second page of the Holiday report is even more interesting. And this second page, Holiday graphed the EKR relative to the pupil size. Usually we want to look at the 4.5 millimeter pupil size because most of our cataract patients are above 70 years of age, and most pupils above the 70 years of age fall in the category of 4.5 millimeter. So take this with a grain of salt. If you're doing your RLE on a younger patient, do check the pupils, but don't depend on the pentacam pupil measurements, because as you all know, when you're taking your pentacam, there's a bright light that shines on the eye, which kind of constricts the pupil more than the usual. If you want your pupil measurement, an accurate pupil measurement, you need to take it either with an aberrometer or with the handheld pupillometers. But usually in the older generation, a 4.5 millimeter pupil is what you want to look at. And this is the other important important graph in this report. It gives you the distribution of the EKR in the 4.5 millimeter zone. What that means is that it's looking at that red line, that red zone, and it's looking at how much, where the patient is looking through that red zone. So here it's peaking up, it's spiking at about 40 and then at about 46. Which corresponds to the two axes of the astigmatism that you have here. And this is very normal when you have a very regular astigmatism, that you have two spikes. So seeing two spikes within a 3 diopter range kind of 3 diopter range of EKRs kind of points to a very normal astigmatism that you might want to treat with a toric IOL. Holiday also graphed how this distribution of the EKR can vary from patient to patient and vary after several procedures. So in a normal population, 3 diopters range with 1 or 2 spikes is typically normal. 1 spike if he doesn't have any astigmatism, 2 spikes if he have a little bit of a regular astigmatism. In the post-LASIK patients, you can notice that this range is much wider, and you might have more spikes because the cornea becomes a little bit more irregular. when it becomes very irregular, like in an RK patient, you have a wide range of EKRs across the 4.5 millimeter zone with a wide range of spikes, and this is a no-no for a toric IOL at this point. So this is kind of gives you a very fast view of whether you can go ahead with a toric IOL or not based on your astigmatism. It will be very interesting when we're talking about the irregular corneas in a little bit. So we've tapped on multiple topics so far, but I just want to clarify why we're talking about all of these corneal powers. So we've talked about the simulated keratometry, which we can derive from the biometer, we can derive from the tomography. It's only the 3 millimeter central zone, the anterior cornea, and we're comparing it to the total corneal power, and then we're looking at the EKR, and Barrett also talks about the calculated posterior astigmatism. So what's the problem with the corneal power? Why are we discussing it so much? And what are we going to choose out of all of these data? We're overwhelmed by data and we want to get the best calculations for our patients. So let's go back to 2013 when Koaik et al. Actually noticed that there is always an underestimation of the astigmatism after cataract surgery. What he's noticed is that because the cornea, the posterior cornea, is typically steeper along the vertical meridian, and the posterior cornea has a negative corneal power as an addition to the anterior cornea, the corneal curvature. He's noticed that that causes an increase in the against the rule astigmatism along the 180 degree, and thus you're underestimating your with the rule astigmatism at 90 degree. What that actually means is that if you're not actually taking the posterior cornea into account, you're usually underestimating your astigmatism by at least 0.5 to 0.6 degree along the 90 degree axis, and you're overestimating it along the 180 degree axis by 0.2 to 0.3 degree. This might not seem like a lot, but if you're treating a low astigmatism patient and the 0.5 to 1 diopter, and you're putting a multifocal lens in him or a diffractive element in him on top of a toric element, you actually want to nail down that refraction to less than 0.5 so that the patient can be happy with the vision. And you don't want to miss on the posterior astigmatism, that can ruin your calculations. The other thing is, we know that we have a lot of patients who have had a difference between the anterior and the posterior curvature, and that difference can be post-refractive in many cases, and we have a lot of errors inherent in our calculations that are exacerbated by that change in the posterior to anterior ratio that happens with the refractive patients. And in those cases, you want a measurement of the cornea that can give you the best accurate, complete measurement of the anterior and the posterior cornea, and decreases your ELP errors and your index of refraction errors that will lead to inaccurate calculations. So going back to which one do we use out of the 5 different methods? Do we go for the SIMK, regular, anterior, basically the central 3 millimeter cornea, which you can either take it from a biometer or from a Scheimpflug, but it's still both ways. It's still only the center 3 millimeter, and it's usually calculated based on the refractive index that was preset at 1.3375, which we now know is not the accurate one because this does not take into account the posterior corneal and refractive index. So do you use the total net power of the cornea, which is another way of testing anterior and posterior curvature, but it's kind of a calculation method? Or do you use a TCRP, which is the total corneal refractive power, which instead of using the Scheimpflug, it uses the ray tracing capacities of the pentacam, and it extrapolates the corneal power based on the anterior and the posterior curvature alone. Usually what we know from several different studies is that the TCRP underestimates the corneal power by about 1 diopter. So it's usually 1 diopter away from any kind of calculations that we have. And typically it is not corrected for in our regular calculations, which are usually made for SIMK, which makes it a bit more erroneous in the amount of in the lens power that it will give after the surgery. So if you want to use the TCP, you're okay to use the TCP, but you need to use the Koaik adjustments to it so that it becomes adjusted to the regular calculations. the EKR 65, which is Holliday's pentacam index, is Scheinflug derived. It is involving the anterior and posterior curvature, but it takes the TCP a step further, and it actually corrects it for the basic IOL formula. So it makes it easy for you to use in the IOL formula, and it's basically using the actual refractive index of the eye based on the posterior and the anterior refractive index. The last one, which we haven't discussed so far, is the Barrett's calculated posterior corneal astigmatism. It's a calculated PCA that is incorporated in the Barrett calculations. What this one does is that it can use the anterior and the posterior curvature measurements that you take out from any kind of tomographer. It's not specific to the pentacam, which makes it so beautiful because you can use it everywhere. And it calculates it within the calculator. We don't know how it does that because it's kind of a black box what's happening with the Barrett calculator. But basically, it also corrects for that buffer error with the IOL calculation. But it also adds a layer on top, a layer of complexity on top. It's that it takes into account the angle alpha of the eye, and it takes into account that basically the lens never sits directly over the pupillary axis and over the central pupillary axis, and thus it always creates an internal kind of astigmatism and an IOL tilt. And it takes into account that that factor when you're calculating your posterior curvature astigmatism, so that you can get to a better kind of refraction. So basically, whichever one you use, you're basically taking the information out of a tomographer in some way. And definitely the SIMK has shown the least amount of correlation with refractive astigmatism, and that was lastly proven in this study in 2019, which showed that you can go with EKR, you can go with Barrett, you can go with CCP, but when you go with SIMK, you're kind of losing a little bit of your accuracy in terms of the residual astigmatism. So now that we know what to do, we know that we need to look at the posterior curvature. We know that we need to look at the total corneal power. Let's see some examples about irregular corneas where things are not so clear. This is a patient who has had PKP, and we actually did her surgery a few weeks ago with Dr. Begg, and she had plus 15 diopters of astigmatism on the IOL master. Do you go ahead and pick the lens diopter that is with that amount of astigmatism? Or do you check your topography? Of course, check your topography. And when you do this EKR reading with the Holiday report, you can see that in the 4.5 millimeter zone, which is the central zone over here, the actual astigmatism that's going to affect her central vision is much less than 15 degrees. So if you had actually gone and did the calculations with that 15 degree, you would be way off in the IOL power calculation. And if you use these EKR, which are easy to use in any IOL formula, it would give you a much better estimate of the IOL power in this very aberrated cornea. So this is one way to use it. Usually try to pick the centralmost zone and try to look at how regular it is in that centralmost zone when you're picking the case to use. Another kind of irregular corneas that we face a lot are keratoconus. And what do we do with keratoconus? Do we go ahead and treat toric IOLs, or do we prevent any keratoconus from having a toric IOL? A good and interesting way to see it is with the EKR report. For example, for this case, this is a patient with obvious keratoconus that you can see on this axial map, and you can see the posterior elevation that's pretty high, and you can see that the pachymen is pretty high. So this is a KC patient, but when you're looking at the semi-meridians that are over here, you see that they're practically irregular all over, even in the central 4 millimeter. And this is confirmed by this distribution EKR over here, where you see that the range of the EKR is pretty wide, but also you have so many different spikes. This patient's cornea is highly irregular and highly multifocal, and that patient is looking through so many different areas of steepness in the cornea that it's probably not a good option to do a toric IOL. What about this guy? This is a patient who obviously has keratoconus. It is slightly more stable in the 4.5 millimeter. You can see semi-meridians that are a bit more regular, but you do see a frank posterior elevation. When you look at the EKR, there is definitely a wide range. This is still a keratoconus patient, but there is only one peak through which the patient is seeing, which is the main axis through which is seeing over here. And using this EKR data in a toric calculator, while taking into account the posterior curvature, can give you a fairly good result with a toric IOL for the patient and their vision. So this might be actually a patient, if motivated enough, he might be a candidate for toric IOL placement with little side effects after the surgery. So now that we've discussed basically the tomography, we've gone over all of the different factors that are in play. My take-home messages for you is to use the EKR in highly irregular corneas when you're calculating your IOLs, especially in the 4.5 millimeter zone. But don't take the 4.5 millimeter zone for granted. If a patient is younger than 70, which is a lot of our patients and a lot of our RLE, then do take a pupillometry measurement before you go ahead and use the EKR with the pupil size, with the adequate pupil size. The posterior curvature is very important, especially in low astigmatism eye. In the high astigmatism, it may play a very small role, but in the lower ones, it can make the whole difference between nailing the refraction and being a little bit off. Spherical aberration is the cherry on top that you can do to add that extra layer of finesse and vision quality to your patients. But always make sure to look at your spherical aberrations whenever you have a refractive patients, because it can make the whole difference in their vision. Moving on to the second part of our talk, it's about ocular aberrometry. We have several aberrometers, but we're going to talk mostly about a ray tracing aberrometer, which is the eye trace. Why are we talking about aberrometry? Basically, we're talking about the quality of the visual system, because we're trying to look at how the wavefront has changed when it went through your visual system, and what kind of errors is the patient seeing out of that. And Zernike made a polynomial for us and differentiated between the first order aberrations, which are the basic astigmatism that everybody has, and the higher order aberrations, which can create a lot of trouble. We've already discussed the spherical aberration that can cause blur and diplopia, but there's also another set of aberrations that occur, especially in abnormal corneas, that can cause coma, trefoil, and everything else. And we need to measure those aberrations in order to be able to tell if a patient is a candidate for multifocal, because, as you know, most of the multifocals today on the market are diffractive elements, and all of these diffractive elements can create an extra aberration profile to the eye, and you want to be sure that it will not conflict with the corneal aberration profile. So many aberrometry methods are on the market today. Probably in a regular refractive clinic, you might see a lot of those together. I'm going to discuss the eye trace mostly, just because it is kind of a holistic machine that we use frequently in our clinics. It has a topography with a Placido imaging. It has an autorefractometry. It is a ray tracing technology, and it takes about 256 individual and consecutive rays of light from the cornea, that go through the optical system of the eye, and it kind of measures the pupillometry because it measures it in a dark setting. And the output of that is so many different maps, a lot of wavefronts over there, and it can segregate them into higher order, lower order, but we need to develop kind of a scale or a step-by-step approach again in order to evaluate the aberrometries that we have. Usually it's multiple pages, and you really need to know what to look for. So we're going to talk about them step by step. First step, you need to look at the total aberrations of the eye. This is similar to the higher order aberration that was on the pentacam, which is also derived by ray tracing. so they're good. But in this one, it can actually break it down to internal aberrations, total eye, and corneal aberrations. Do make sure to look only at the corneal aberrations whenever you're pre-oping a patient for cataract, because this is what's going to remain after the surgery. Yet pay attention, if a patient has endothelial disease, usually any endothelial disease can cause aberration profile, and that aberration profile will look in the internal aberration rather than the corneal one, because this is an anterior curvature derived data mostly. And usually, as we mentioned previously, if the higher order aberrations are more than 0.5 micrometer, this is concerning, and you might want to err on the side of not putting a multifocal IOL or a diffractive element. If you have severe aberrations more than 1 micrometer, definitely don't do that. Also, from this, this is called the Chang analysis. And from this Chang analysis, you can see the tracy autorefraction. And when it's green, it's actually giving you a pretty good refraction, which is actually really nice so that you can evaluate the patients even faster. The second item to look at is the optical quality meters, and that has two folds with the eye trace. The first one is the point spread function, which actually shows you how the image is spreading on the retina when it goes through your optical system. In a perfect eye, it shouldn't spread at all. It should focus all in one position. But in an aberrated eye, either because of cornea or lens, you will have the images all over the place and highly aberrated. This is more of a qualitative way of looking at the quality of the eye, the optical quality of the eye. A more quantitative way is looking at the contrast sensitivity and the resolution, and that is through the modulation transfer function, the MTF curve. Again, look at the corneal MTF curve, and you usually take as a reference here 10 cycles per degree, which is right over here, and you want it to be above 40% contrast sensitivity. So any curve that is above that actually represents an eye that has a good contrast sensitivity and should be okay to go for a multifocal IOL. Eye trace also allows you to simulate the vision, and that is quite interesting because one, you can show it to the patient, and two, you can tell exactly what you're going to end up with as a vision after the surgery. Okay, because you can see that this is the internal profile that is really bad, but the surface looks pretty okay. And it gives you also an axial map, so you can see the Placido images on the surface. Always look at the angle kappa and the angle alpha before you schedule any multifocal surgery. A lot of people are debating whether this is useful or not. This basically gives you an idea of where your IOL is going to be centered inside the eye. So the angle kappa is basically that visual axis with respect to the central of the pupil, whereas the angle alpha is that visual axis with respect to the center of the limbus, how far away they are from one another. And as you can see here, those three dots are in this picture very close together, but this is not actually the case all the time. In a normal cornea, the visual axis over here is usually more temporal than the pupillary center and then the ocular center, which means that you have some angle kappa and some angle alpha in any normal eye. And the usual numbers are usually less than 0.6 and 0.4 for a normal eye. So basically what you're saying is that when your lens is gonna sit in and it's going to be centered over the pupillary center, the first layers of the diffractive rings are going to fall off on your visual axis if those angles are way too big, which can create a lot of glares and halo. And this is why it's very important to keep those numbers below 0.6 and 0.4. Definitely not to be taken for granted all the time, but at least as a general indication of how to use the lenses and where the lenses are going to fall off after the surgery. The last but not least, with the eye trace, you can also look at the dysfunctional lens index. As Waring et al. Actually redefined dysfunctional lens syndrome, which is kind of another way of looking at cataract. It's not only with lenticular opacities or the inability to accommodate that we usually know about cataract, but it's also with the changes in the aberration profile. And in this view, you can look at how the lens is changing the aberrations, and you have an index that is set by the eye trace that can give you where where the lens is with the aberration profile. If it is above 6, then actually the aberration profile is okay, and this is not a cataractous eye. So this is another way to look at the cataract other than the Scheimpflug image and other than your actual exam. So I'm going to move on to one last case just to illustrate all of the items that we've just discussed. This is a 61-year-old woman, who presented with vision decrease to actually Dr. Begg's clinic. She is a 20/30 vision pre-op with a hyperopic and a little bit of astigmatism, a 0.5 astigmatism, that's it. But she also has corneal gutta on exam, so she has a little bit of an early Fuchs. Very early, because as you can see from these pictures, that the pachymetry is very thin, is very normal. There's no thickening there. You can see a little bit of an irregularity in these anterior curvature maps, but the general astigmatism is pretty low. When you look at the holiday report over here, you can see that there aren't many spikes with a very low range, which makes this a patient that is pretty eligible for toric IOLs if she needs it. And even over here, and the EKR maps are pretty good. If you look at the IOL master over here, you can see a bit more astigmatism than what you were seeing from the topography, which illustrates again how the small samplings of the keratometry here can be misleading. Looking at the eye trace, we're trying to decide here if we're going to go for a toric IOL, for a multifocal IOL. This is a patient who wants to get rid of glasses completely. And looking at those numbers, you can see here that the higher order aberrations are low in the cornea. You can see that the angle alpha is borderline. The eye trace gives you when a red sign or an orange sign when the items are borderline, and an angle kappa that is okay and normal. That's for the right eye, and it gives you a good MTF curve with above 40% here for the right eye. So far she's borderline eligible in the right eye. For the left eye, she has better numbers for the angle alpha and the angle kappa, and her cornea's internal and her corneal higher order aberrations are quite okay. Looking at the MTF curves for the left eye, it's falling just on point. This patient was highly motivated. She expressed several times wishes to actually be spectacle independent, very pleasant personality. We ended up putting a PanOptix IOL on her despite those borderline values here and there, and the patient ended up being very happy with the 20/20 vision despite the corneal gutta, and we didn't end up using any toric IOLs because the EKR readings were so low. So in conclusion, each of the indices alone in the eye trace is not a complete contraindication or indication for a premium IOL. You need to put everything together, but very crucial is to involve the patient and assess the patient's personality in the decision-making process, because that can make all the difference with these IOLs. These are my references, and thank you. Do you have any questions?
Wow, that was awesome. You should come up for some air sometimes, because you were talking right away. Well, that was really good. That was really, really good. So I think you gave a really nice overview of how refractive cataract surgery, refractive lens exchange, cataract surgery in general is going. If you were to have your new clinic starting up, what key diagnostic pieces would you want in your clinic when working out the cataract and refractive lens exchange patients?
Everything? Is that an answer?
Yeah. So, like, for example, you know that many people don't have aberration analysis when they're doing cataract surgery. Many people may not have tomography. So, what would you say are some of the critical pieces that you would want to get into and have at the very minimum?
So at the very minimum, I would need a pentacam with a Scheimpflug, at least a Scheimpflug technology. Galilei or Sirius also have Scheimpflug technologies, and they're really good, especially if they have an additional ray tracing, at least at evaluating the higher order aberrations, the angle kappa. It doesn't give you a full picture of everything like the eye trace does, but it does give you a general overview if you need to be at the absolute minimum. But once you're starting to deal with the refractive patients, you want to also be certain that these patients are not going to have a lot of aberrations after the surgery. And eye trace or any other form of aberrometry, like ray tracing, can give you a better picture of what the visual function is going to be for the patient after the procedure. Also, all of the newer technology that allows you to evaluate where the patients are seeing, what are they seeing, what are they comfortable with, the simulators, all of these add an extra layer, but at least at the very minimum, you need those two instruments and possibly a wave scan to kind of determine where you're headed in terms of your refractive outcomes.
Okay. Another question often comes up is that, it's good to hear about this, you go to conferences, you take some notes, but then the reality of it is a little bit different. So we have some of the technologists on our meeting as attendees. As a surgeon, what would you say to your tech colleagues who are doing all the workups and doing the diagnostics, and this is what you're using to interpret to make your surgical decisions? What would you want them to know?
First, thank you, because without them, we can't tell anything to the patient. Second, especially with these advanced technologies, it's highly operator dependent most of the time, especially with ray tracing technologies and the stuff. So it's really important to take them in mesopic conditions, to take them, to take your time, to repeat the scans if you're not comfortable with, to make sure they're centered on the visual axis, because all of that can change what we're seeing at our end and can change our recommendations for the patients.
Okay. And what about the lenses that are out there? So, it's one thing to get the diagnostics done and figure it out. What do you use to figure out, okay, I've got the diagnostic, I have an understanding of what the eye is all about. How do you make the kind of connection with what kind of lens you'll be choosing?
So basically, after you've gone through the different steps, there's only a few lenses that would be available for every patient that would actually fit the visual quality that they are needed. And typically availability is a big issue. Experience with the lenses is another big issue, and that doesn't mean that you won't try new lenses, but it really depends on all of the different items together, and you really need to be up to date with everything that's available out there all the time.
Okay. Okay, now suppose you've done your surgery and now you put in a toric lens, and you mentioned the importance of the posterior corneal astigmatism. Suppose you're off a little bit or the lens is rotated. Can you explain how you've used the aberration analysis to figure out what to do with an unhappy toric patient?
So the aberration analysis with the eye trace, it has a very nice toric planner that you can use for the pre-op with toric calculations. I didn't go into all of that. And you can do it for the post-op, where you can actually sit the patient back again, and it can give you a refraction, and it can compare the refraction to what the target's residual astigmatism should be. So it kind of works like the astigmatismfix.com, and it gives you a way to rotate the lens that you can follow. What we typically do is we kind of go with the eye trace for once, and we use the astigmatism fix, and we combine the data in order for us to get a feel of where the lens should be rotated if need be.
Okay. And then finally, when do you trust the readings from the pentacam tomographer or the eye trace? Some patients coming in with ocular surface issues, some patients are post treatment for, keratectomy for, say, anterior basement membrane dystrophy. At what point do you say that now this is the point where I'm going to trust these numbers and rely on these numbers for my IOL calculations?
So typically with patients with ocular surface disease, the changes will happen on the anterior curvature. You will have a lot more aberration profile with the eye trace and with the higher order aberrations that are in the pentacam. But typically what we end up doing is seeing the patients again and again until we have at least 2 measurements on the pentacam that are kind of stable, and until the exam on the surface of the eye is better and more stable. So a patient with a lot of erosions will definitely have a lot of error in the measurements on the surface of the cornea, and so you really need to repeat it until you're definitely certain that it's stable.
Okay. Any questions from the audience? Any comments? No, I don't think so. I think that one of the things that we're all having trouble with now is that there's an ever-expanding toolbox of diagnostic equipment that's coming out, and it's getting hard to know what to trust, when to trust it, what to use, when to use it. Is it worth buying this technology? So thank you very much, Mona, for kind of giving us in a very succinct way how tomography can be used as well as aberrometry. I think I do agree with you that these two pieces of diagnostic equipment can really help to make life a little bit easier when looking at these lenses and lens selections for some of these advanced presbyopic correcting lenses. I think it's made my life a little easier in the sense that when I do recommend a lens, I have a bit more confidence in recommending it. So I do find it's something that I think we'll all be using. Do you have any comments for some of the optometrists in as the attendees? Optometrists who will be, seeing these patients, then referring them at one point for either refractive lens exchange or cataract surgery. What should they be telling their patients?
Honestly, at this point, there's always should be a discussion about the presbyopic options for corrections and about the total health of the eye. So what I didn't mention here is that in addition to all of the corneal measurements that you need to have, whenever you're talking premium IOLs, you also want to talk that the back of the eye is stable, that they don't have any nerve damage, any glaucoma, because all of that can affect your contrast sensitivity. So from the optometrist perspective, it's really important to make sure that the ocular surface diseases are controlled before they send them out, to make sure that they discuss premium IOLs in case they start the discussion of premium IOLs in case they are eligible, and in case they are not, to set the expectations a little bit that they are not going to get an intermediate and near vision with a correction if they have AMD on board. And a lot of patients kind of come in and are expecting a total presbyopic treatment when in fact we cannot offer it to them because of those diseases.
Okay. We have a question from the audience. When using EDOF IOLs, extended depth of field intraocular lenses, are you using the same outline for higher order aberrations, the same cutoffs for higher order aberrations?
So it's not as strict as when you're using diffractive elements with multifocal IOLs, but you can give a little bit more leeway with the EDOF, we found in the past few years' experience. But you still have to make sure that your cornea is not highly aberrated and that you still have a good contrast sensitivity before you input any EDOF too.
Okay, I think all these are always balanced, as we always do, by making sure that we talk to our patients and see what they're into, right? And what some of them are very kind of forgiving and they're not too keyed up on it, and some are very, very, very particular. So it also makes us a good. I always make a note in terms of how particular they are, so that it makes kind of matching up the lens a little bit easier as well.
Exactly.
Cool. Any other questions? So I think what we'll do, Vicky will send out the link for the certificate of attendance, so we can send that out. And if you guys don't mind, at the end, it'll be a little questionnaire to fill out, answer that. Mona, thank you so much for your time. It's been super useful. It's going to be, again, it has been recorded and will be put on our YouTube channel as where all the other recorded sessions have been. Have a great evening, and thanks again for your time, Mona.
Thank you. Thank you so much.